Do you think we should start?
Okay, sir.
All right. Sorry for advancing the time because I had to go somewhere till 1 o'clock. So we will try to finish this as early as possible. Now, you had to do talking, not me really. So I will be asking some questions and then you had to do the talking. Right? So it's a tutorial, it's not a lecture. So let's read the question. A 56-year-old woman with a shortness of breath on exertion, 6 months. And she has been previously well. So she has not been on a medication, obviously. Examination BMI about 25 to 26, and she's afebrile. No cyanosis or pallor. And she got finger clubbing. And there seems to be crepitations in both lung fields, bases. Rest of the examination unremarkable. Okay. So can somebody answer the first question? List two possible diagnoses. Hello? Hello, can you hear me?
Yeah, bronchiectasis and interstitial lung disease.
Okay, any other possibilities?
Mesothelioma.
Any other?
Interstitial pneumonitis.
Interstitial pneumonitis, right? Right. Okay. These are no other possibilities. Shall we take now? If I was giving marks for this question, this is a typical final year question. I would consider that first question is as the entry point to the whole question. This is the entry point. This is where we focus onto the rest of the question. Okay. So when you ask the possible diagnosis, we're asking for the things which are very likely and the things which you have probably seen. Because we never ask you for something that you have never seen in your clinical practice. Because we are training for what's called basic doctor who's going to work in this country. And then it's very much the finally in the paper, all the clinical scenario, all the clinical conditions or the diagnosis that we address there or expect the answers would be the ones that we have probably seen during your pre-medical appointments and during your short appointments, medical related short appointments. So if you think that the condition that you have seen during that period and all, so which condition out of those would be the most likely if you want to get marks? So marks would be given in a sort of weighted manner. I think bronchiectasis would be one of those, ne? Yes?
Yes.
Okay, bronchiectasis, because you know, make a crepitation, clubbing. So crepitation and clubbing, bronchiectasis, otherwise will be interstitial lung disease. Interstitial lung disease, or what's called idiopathic pulmonary fibrosis, right? So those are the conditions where you can get a finger clubbing and then crepitations and usually involving both sides. Mesothelioma usually present as what's called the thickening of the parietal pleura. So you will detect that on a chest X-ray, on somebody's taken chest X-ray for some reason, and you find that the parietal pleura has got little lumpy appearance. So it's called lumpy and bumpy, little irregular parietal pleura. Usually parietal pleura you can't see very much. It is just along the rib cage. But if you see a little bit of irregularity, then that is due to a little thickening in this thing, and that is where we suspect that whether patient has got a early mesothelioma developing. But generally, when they come to clinical attention, they come as a pleural effusion, usually unilateral pleural effusion, right? So mesothelioma, they come as a little bit of solid mass in the pleural space or a pleural effusion, right? So I would not consider that. The other condition that the pneumonitis thing, we have what's called organizing pneumonitis, various pneumonitis and all. One thing is they are rare. And this clinical picture does not fit into that actually, because patient has got a clubbing And this clinical picture does not fit into that. So if I was trying to get maximum marks out of in this question part 1, I would say write bronchiectasis and lung fibrosis, and because they are the undisputable sort of diagnosis in this one, no one can test, they are unlikely or something like that. Now I would have given something like about 20 marks for that section. Right, so you can see how much marks that you can get out of that. So 20 marks. If I had written both conditions, then of course you get 20 marks, no problem. Now shall we come to the other part, what is called the what features in the history and examination would help you to differentiate between the condition mentioned in 1. Can I have somebody answering that? What features in the history and examination?
In bronchiectasis, most probably the patient may have had tuberculosis, because bronchiectasis is more common with post-tuberculosis patient.
Okay. So if the patient has got, so in the history, what you elicit is whether the patient has had a bronchiectasis in the past. Okay, so if the patient had a bronchiectasis in the past, tuberculosis in the past, and then the patient has been treated for tuberculosis, and you think, well, this is more likely to be post-tuberculosis bronchiectasis. Agree. Okay. Anything else?
We can elaborate more on the clinical symptoms, such as in bronchiectasis, there is a copious amount of sputum production, where interstitial lung disease is, it is mainly dry cough.
Absolutely, that's fantastic. That is one of the key feature, right? And in the history, shall I just finish this and come back to your very important point? And then you asked about the past history of tuberculosis, because if the patient had tuberculosis, probably you are dealing with bronchiectasis, post-TB bronchiectasis. And also it's important to know about the childhood infections, and you remember that in childhood infections, and then they can end up with the bronchiectasis in the later age, right? So you asked about the past of pneumonia, particularly in the childhood, or maybe even after that, and then how long they were in the hospital, whether there was a concern about the doctors, whether they did repeated chest X-ray to see whether there's a resolution of that one. So you asked about the childhood lung infection as well as a difficult lung infection that patient has had. Maybe that patient had poorly resolved in pneumonia, and then as a result, bit of lung fibrosis, and then not with tuberculosis, and then ending up the fibrosis. So in the history, you elicit the history of childhood lung infections and the poorly resolving pneumonia afterwards, and also of the history of tuberculosis, because all this would support, I'm not saying that, either support the diagnosis of bronchiectasis in the latter age. So that's important one. Are we agreeing with that? Yeah.
Yes, sir. Yes, sir.
Okay. So that's one important point. The second point is that what you said, actually, because the patient with the bronchiectasis produce a copious amount of sputum, in contrast to patient with idiopathic pulmonary fibrosis, where the alveoli are generally dry and they don't have anything very much secretion in the alveoli space, and then they don't have that much of expectoration. How does this bronchiectasis, the sputum is described? What is the typical description in the textbook?
Copious amounts of productive.
Yeah, it's called mucopurulent sputum, isn't it? Book says a copious amount of mucopurulent sputum. So if you have ever seen that sputum mug, right? In my days, of course, we didn't have CT, and then we had to go for a sputum mug and all. So when you open it and see, you can see that the lots of it's almost 1/4 of that is filled, and then you can see this mucus plug and then little bit of pus in between. So typical what's called mucopurulent sputum. So the patient with the bronchitis would be expectorating a large, a copious amount of mucopurulent sputum, in contrast to a patient who has got a fairly dry cough, if they have. Okay, agree. Anything else?
Hemoptysis.
Sorry? Yeah, that's right. Okay. Recurrent hemoptysis. If the patient had a recurrent hemoptysis, that is swing more towards bronchiectasis. Okay. Some more. Now, if the alveoli spaces are generally dry, because in the interstitial lung fibrosis take place in the interstitial tissue, isn't it? It's not within the alveoli. Whereas in the bronchiectasis, you know that the most of the changes are within the bronchial wall, the bronchial cavity, this bronchial lumen, and as well as in the alveoli. So the patient with bronchiectasis would have cough. So the patient bronchiectasis has got recurrent cough, but then the patient with the interstitial lung fibrosis, the cough is minimum because there's nothing very much to cough out because no secretion and no pus, and then patient does not have to expectorate anything. So as a result of that, patient doesn't have a recurrent cough. So recurrent cough is generally very rare in patients with interstitial lung fibrosis. And in contrast, patient with bronchiectasis patient, of course, has got that problem. Okay, so one is the cough is rare, and if they cough, they produce large amount of sputum. Okay, anything else about the cough?
So the cough can be changes with the posture?
Absolutely, that's what I was expecting. So this patient I can lie on my left side, because in a moment I lie on my left side and then I start getting cough. So that is because of the postural drainage, because patient keep this one up and then try to sleep, and then a little bit of the sputum secretion will come down, and then we'll have irritation of the airway, and then patient get a cough. So this was called positional cough change with the position is a very much a feature of bronchiectasis. And this is just give me 1 sec, okay? Hello, sorry about that. Yeah, okay. Now, what is the other condition where the patient has got patient get cough when the patient change the posture? What's the other differential diagnosis?
Lung abscess. Lung
abscess. So these are the two conditions that you must always consider. And the one is that the lung abscess, where you can get a cough change with the position, and also the one's bronchiectasis. So one is so three things you have to remember. One is that the cough is minimal in interstitial lung disease. Cough is more common. Chronic cough is more common in bronchiectasis. That is posture dependent, and also they bring out large amount of sputum. Right? Okay, that's okay. Anything else? So that's good. Anything else?
Halitosis can be there.
Right, halitosis and hemoptysis. Right. Anything else? Now, you know about the wheezing, ne? Can you tell me the condition where you can get recurrent wheezing? 3 common condition or 4 common condition where you can get wheezing? Because all wheezers are not asthmatics, ne?
COPD,
asthma,
aspergillus, bronchopulmonary aspergillosis.
What about bronchiectasis?
Yeah, bronchiectasis also.
Bronchiectasis as well, ne? Okay, 1 second. Vaji? A lot of background noises, so I have to shut that down. Sorry about that. Okay. So bronchiectasis, if you remember that the patient of bronchiectasis, one of the presentation is they can present with recurrent wheezing. And that's because we know that the wheezing is very much due to a narrowing of the airway. And then patient with the bronchiectasis can have inflammation. And as a result of that inflammation, you can get narrowing of the airway. And then these people can present with wheezing. So remember that if somebody is present with the wheezing for the first time, and then you must bring the possibility of bronchiectasis into the differential diagnosis, and that patient may not have actually asthma, may have a bronchiectasis. So wheezing is another feature that you differentiate between the two conditions. So we have got a wheezing, a cough, position of cough, lastness, sputum. So that's bronchiectasis. Okay, anything else? Hello?
Signs of copulmonale can be there.
I thought they both can end up with copulmonale. But then the desaturation is commoner, is early with the interstitial lung disease. So you find the central cyanosis, they both can get central cyanosis. There's no question about it, because they can get central cyanosis, they can both end up with the copulmonale, they can progress. But then this more than bronchiectasis, people with interstitial lung disease has got tendency to get what's called desaturation. So they are more likely to develop central cyanosis and much earlier than bronchiectasis. So if they get central cyanosis, then of course again you think of more of interstitial lung disease, so you can get in bronchiectasis as well. So early cyanosis, early central cyanosis is a feature of interstitial lung disease. Right, now shall we come to the examination of the lungs, examination of the respiratory system. What are the features that will suggest bronchiectasis or interstitial lung disease? Hello? Hello?
So there will be central cyanosis
Okay.
sometimes and clubbing.
Examination of central nervous system. Sorry, examination of respiratory system. Yeah.
Breathing movements will be equal on both sides. Breath sounds. Chest expansion will be also similar on both sides.
I'm listening. How to differentiate between the two based on the lung signs.
The crepitations will be more cause in bronchiectasis and usually find end inspiratory crepitations in interstitial lung disease, both bilateral though.
The typical description in the textbook, when they say lung fibrosis, interstitial lung fibrosis, and what they say is a Velcro. Have you heard about that word Velcro? VELCRO, Velcro. Velcro is that kind of textile. Velcro type crepitation. Those are very coarse crepitation actually. So in both conditions, you can get a very coarse crepitation. In bronchiectasis, of course, coarse crepitation. Very early on, you can get what is called the very fine inspiratory crepitations in lung fibrosis. But by the time they come to a doctor, they have usually very coarse crepitations. So the presentation to a doctor usually coarse crepitation. But to begin with, they have got a very fine basal crepitations, inspiratory. Bronchiectasis is more like to be asymmetrical, isn't it? Because it is infection, and infection can generally affect two lungs in different extent. But whereas interstitial lung disease is a more of a general condition where the disease is more symmetrical. So when you examine the lung bases, you will find that in bronchiectasis it might tend to be asymmetrical in the distribution, but whereas interstitial lung disease will be bilaterally and symmetrical. Okay. That's because it is driven by a, let's say, immunological phenomenon. So when the immunological phenomenon comes into the picture, usually it is bilateral and bilateral and symmetrical kind of thing. But if you get an infection, bronchiectasis due to following an infection, is tend to be asymmetrical than symmetrical. Okay, so bronchiectasis is symmetrical, whereas the interstitial lung disease would be symmetrical. Okay, anything else? Again, something about the crepitations. Now, we said that the cough is postural, isn't it? In bronchiectasis, right?
Yes.
Yes, okay. Now, something of the crepitation in the bronchiectasis is that you get the patient to cough, you listen over area, get the patient to cough and produce sputum and spit it out, and then you listen. And when you listen, you find the crepitation is less in that area now, right? This is, they give what is called post-tussive. So patient take a deep breath and cough and produce sputum, And then after that, you find that the crepitation, the intensity of the crepitations are less. But it doesn't happen with interstitial lung disease because because there's nothing that in the lung, in the alveolar space, and as a result of that, it doesn't change very much. It's a very interesting phenomenon how you get crepitation, isn't it? Because you think the crepitations are due to fluid in the alveolar space. That's what we all thought, ne? We all them as a medical students, you say pulmonary edema. Pulmonary edema, you get a fluid in the alveolar space where the air goes to the alveolar, this thing, you get a bubbling and get crepitation. That's what usually we believe, isn't it?
Yes.
That's what you still believe, isn't it?
Yes.
Yeah, that's right. So, but again, you can get crepitations here without any fluid in the alveolar space. Do you realize that?
Yes,
So
sir.
in this situation, you have got crepitations, but then that there's nothing in the. So it's a very interesting phenomenon why people get crepitations, right? In the respiratory illnesses, and there are a lot of theories, but I don't think you have to study any of those things. And but it's an interesting phenomenon because some people can have crepitation, showers of crepitation, extensive, but then still they don't have anything in the alveolar spaces, right? Anyway, so here the thing is that in bronchiectasis, the crepitations tend to change with after coughing, tend to be asymmetrical, right? So those are the two things that you can do at the bedside. And also they can get wheezing because if they can get bronchi, if they can get wheezing, they can get bronchi. So patient with the bronchiectasis might get few bronchi here and there. So, but that you would not get with the interstitial lung disease because it's predominantly in the alveolar space and not involved in the airway. Is that clear?
Yes, sir.
Okay, so we know quite a lot of differences, and in fact, when you come for the short cases respiratory system examination, when you get a patient with bronchiectasis, we always pose this question: what is your differential diagnosis? So we expect you to say it's interstitial lung disease, and the next question would be that how to differentiate by just listen to the lung, how to differentiate. So we expect you to know these answers, right? So that's become very important in the short cases as well. Anything about that examination part? So I will just go through that. What is this third one? Third one about the investigation, is it?
Yes, sir. Yes.
Okay, right. Okay. So now tell me that investigations would depend on the condition that you suspect, isn't it? So tell me what investigations should you do now?
So excuse me, sir.
Mm-hmm.
Sir, are there any difference in percussion note in lung fibrosis and bronchiectasis?
Now, basically in in bronchiectasis, what you get is actually inside this thing, you get a fibrosis. Again, the same thing is that fibrosis. But if you get a superadded infection, you can get a consolidation and you can get a pleural effusion. So bronchiectasis complicated with a consolidation would have features of consolidation. So patient with a bronchiectasis can present with what's called community-acquired pneumonia, and then you can get what is called features of consolidation. And also patient with a bronchiectasis can present with a pleural effusion, infective pleural effusion, and you will have features of a pleural effusion. But if you take bronchiectasis per se, you got only the lung fibrosis, right? So on the other hand, if you take interstitial lung disease has only lung fibrosis. So what is the typical percussion note that you get over an area of lung fibrosis? How do you describe? Over area of lung fibrosis, what is the typical percussion that you get? Abnormal percussion abnormal you get?
Dull.
Any other opinion?
Bilateral basal dull percussion note.
So it's still dull, is it?
Yes, sir.
Bad percussion.
Oh, what is that? That is the one. So you get let's say you get a hyperresonant when patient has got, let's say, the pneumothorax, right? Then you get normal percussion note in normal people. Then you get what is called impaired percussion note for an area of fibrosis, right? You get dullness or a consolidation, and you can get a stone dullness or a pleural effusion, right? So that's a spectrum of percussion note, right? Most of the textbooks actually they have forgotten that and they don't describe that sufficient enough. In fibrosis, what you get is an impaired percussion note that is between normal and dullness. Difficult to tell you what is impaired percussion note unless I got a patient who has got a lung fibrosis. So remember that if somebody asks you what is the spectrum of percussion notes that you can get in disease conditions in a normal person, then you get from the hyperresonant in pneumothorax, then you get normal, then you get impaired percussion note in fibrosis, then a consolidation, you get dullness, then you get a stone dullness in when there's a pleural base tumor or when there's a pleural effusion. Okay, so if the patient has got only bronchiectasis and no complication at that time of the presentation, and like a pleural effusion or a consolidation of the lung at that time, and you would find that patient has got only impaired percussion note on that side. So is the same with the lung fibrosis. So it would not differentiate between the two unless the bronchiectasis is complicated with something.
Thank you, sir.
Okay. So you go to the investigation part. What investigation would you do?
Yes, sir. High resolution chest CT imaging because chest X-ray won't give much information.
We won't get any information, is it? It won't give any information.
No, sir, it will give.
Now there's a little game that you have to learn here. Now if this question was asked in the long case examination, right? You are asking about the practical situation. What is happening in the world? If there is asked something in the question paper, now you have to write a most profitable answer where you will get most marks. So how you handle this question actually is different in the event that they were asked. Now let's say if they were asked in the long case that you have a patient of this nature, long case, now you will get irritated. The examiner will get irritated if you say one of the sophisticated investigation first, because we don't do that manner, isn't it? Because you will always do what are called basic investigations, a less expensive basic investigation, and then only you will think of doing a more sophisticated, more expensive investigation that is in the hospital scenario, the real scenario. But if you are doing writing an answer to a question, then you are not thinking of that much. You are writing a most important investigation that would differentiate between the two, right? Now, for example, let's say if the question was asked in the ward setup, I would say I will certainly do a full blood count and the inflammatory marker, because that is what the house officer will order, and that is what all the patients will get, right? Though they have a little bit of discriminatory ability, but then generally they are unable to discriminate between the two, but they all get it, right? So if you are answering that question in this thing, you would say, I would start with a basic investigation before I consider a more specific and expensive investigations, and then you will go with that. So no, you will not irritate the examiner. But in order to get enough good marks in the written paper, then I would write investigation which are very profitable and which will definitely discriminate between the two first. First, I will say, if they say write 5 investigation, I will write those 5 which are very, very important ones, right? And push the others below. Now, before I go to HRCT, I will certainly write a chest radiograph, because however much you say, there are patients who will stop at chest radiograph. Let's say you have got a 70-year-old person who's coming with clinical features of this nature. You did a chest radiograph. and found that patient has got a kind of cystic lesions bilaterally and extensively. And then you don't have to do HRCT because you're not going to operate on this patient. You're not going to sort of do anything. So that patient only will stop at level of chest radiograph as far as the imaging is concerned, right? And then if the patient has got a normal like chest X-ray, because bronchiectasis cannot be ruled out on normal chest radiograph, and that patient might go to HRCT. Outpatient, young patient, somebody might say, hang on, shall we think of little more investigation on this patient? You might do it. So I would still write a chest X-ray as sort of investigation of choice, and which would discriminate between the two. Okay. Right. So first one will be chest radiograph. Right. Okay. Chest radiograph. Second investigation, HRCT. Right. Hello.
Thank you.
Okay. So second one, yeah, second one will be HRCT. So I write HRCT, and HRCT will definitely people will consider doing HRCT in this patient, particularly when you differentiate between the two, and that in the extent of the involvement, and then of course you will do HRCT. So chest X-ray first, and then followed by HRCT. What are the other investigations?
Lung function test can be done.
We don't do that in very much in the bronchiectasis, really. Bronchiectasis, we don't do lung function test, and then we generally do it in this one interstitial lung disease, because we follow up patients on that, because we do a lung function periodically and then see how they progress. So lung function test is particularly important when you come to lung fibrosis. Okay. Any other investigation?
Is sputum for stain and culture?
Yes. Because you need to rule out the possibility of an ongoing infection. So you always will do a sputum gram staining and also sputum culture. And if the patient has got a high fever, then of course you would consider doing a blood culture. So as far as microbiology is concerned, you think of a sputum gram stain, and you will think of sputum culture. If the patient has got a fever, constitutional symptoms, you would think of doing a blood culture. And in our country, before you embark on any other treatment, certainly because the first time you need to rule out the possibility of tuberculosis. And so doing an investigation for tuberculosis also is not bad, because the patient has a lung fibrosis or bronchiectasis diagnosed for the first time, and then somebody would like to know whether it's not tuberculosis, there's not ongoing tuberculosis. So you will certainly try to eliminate that. So those are the microbiological tests that you do. So one is the imaging chest radiograph and HRCT. In the microbiology front, you will do a culture, try to extrude tuberculosis, a blood culture, sputum culture, those. And then on the other hand, you will try to do inflammatory markers, because that comes in the management, because if the patient has come with an infection, and the patient will have a high CRP, ESR, and then with the treatment, they would come down. So, to assess the progression, and then the response to treatment and all that you will do then. Okay, so these are the ones. Lung biopsy, because if you think of the patient is a interstitial lung disease, and some people prefer to do lung biopsy, so they start treatment, because what they say is that the response to treatment is judged by the lung biopsy. Because if the lung biopsy shows that it is not very much cellular, it is all fibrous, then of course nothing very much you can achieve with the treatment. But if the fibrosis is not very marked and the patient has got a more cellular reaction, then of course those patients would improve. So lung biopsy not only will confirm the diagnosis in interstitial lung disease, this also will indicate how much improvement you can get achieve with the disease-modifying drugs. So that's important. So these are the type of investigation, lung function test, of course, and then patient this one will definitely get something like immune markers like rheumatoid factor and the ANA, because they can be positive. Right? All right.
Yes, sir.
Right. Okay. So that will be the sort of comprehensive type of investigation you do. I mean, you can do other investigation as well, but again, these are the kind of reasonable set of investigation that you would do. Management. How do you manage? So let's take one by one. Which one? First, bronchiectasis, how do you manage? Can somebody answer?
If the patient is having an ongoing infection, we need to give antibiotics according to the suspected organism.
Yeah. Right.
And the patient may need a bronchodilator inhaler therapy. We can nebulize the patient with salbutamol. And corticosteroids also may be helpful. And mucolytics.
Yeah. Right. I don't know whether other people heard because the voice is getting broken. Can you hear me? Is it something we do with me?
Yeah. Yes. No, I can hear you.
Right. Okay. I think you said that right, because it depends on bronchiectasis. It depends on where you're going to see the patient. If the patient is stable and coming to the clinic, the management would be different from let's say from a patient who has come to the hospital with an acute infection. Okay. So let's say a patient has come with an acute infection, acute lower respiratory tract infection at the hospital, and then first of all you will try to isolate organism because that will help you very much. So you try to isolate organism by doing sputum culture or blood culture. Depending on the patient's severity. Here, one of the problem is that the blood culture, if you can get a positivity, and that is more specific, and then you can say, well, that is the most likely organism causing the current illness. But if you get a sputum culture in this one, you might end up with something like a 2-3 organisms, like maybe more than one organism, because you can have a let's say very extensive flora inhabiting that bronchial tree. So you might culture something which is not the positive organism at that particular infection. Say you have isolated Klebsiella, but the Klebsiella is not the one causing infection at that time. It's only just happened to be a sort of residing there and is there but not causing a current infection. Then if you get a blood culture tend to be more specific there. So remember the limitations of the sputum culture, but then we always do that because our main concern is whether the patient has got a Pseudomonas infection, because Pseudomonas eradication is fairly pretty difficult. And so your main concern is whether the patient has got a Pseudomonas infection. Okay, so antibiotics, and then if you've got a cultures, you back by the cultures, and then you can choose the correct antibiotic, and then otherwise you give what's called broad spectrum antibiotic. Either you can give IV antibiotics or oral antibiotics, and these they both can be given depending on the patient's severity. But only thing, remember that you need a prolonged antibiotic treatment. For example, that it's not like a pneumonia where you terminate the treatment on the 7th day or something like that. But here you need at least about 14 days of antibiotic, because you need a prolonged course of antibiotic in patient comes with bronchiectasis, right? So antibiotics, a broad spectrum or specific depending on the cultures, given for a long time, either oral or IV, depending on the patient condition. Some people tend to give what is called the inhaled antibiotics. We don't do that. And particularly when you find the patient has a Pseudomonas, and then people tend to get what's called the inhaled gentamicin. Other countries, they give that, but we don't practice that very much really. So remember that one of the options of giving antibiotic for a long time is giving inhaled antibiotics for those people, right? So antibiotics can be given in 3 different ways. As you said, we'll give bronchodilators, and they can be on the short-acting bronchodilators. Also, they can be on long-acting bronchodilators in order to get the secretions out. And then mucolytics. And don't forget mucolytics. When you say mucolytics, and remember, hydration, good hydration is the best mucolytic. And patient dehydrated, patient can't produce sputum. Patient hydrated very well, and then patient can produce this. So always, if somebody asks what is the best mucolytic agent, say hydration. Proper hydration is the best mucolytic. Otherwise, the patient is dehydrated, and that patient cannot expectorate, right?
Excuse me, sir.
Yeah.
May I ask a question?
Sure.
So, in an infective exacerbation of bronchiectasis, what is the empirical treatment that can be given, whether it is ceftazidime for pseudomonal coverage or amoxicillin and other ciprofloxacin and others?
Yeah, if you're not backed by the if you're not backed by antibiotic cultures, we don't know the organism. Then of course we have to go broad spectrum antibiotic which will cover the pseudomonas as well. But that's depending on the patient's severity. If the patient is not very severe, and you can certainly, you can divide them into a severe category and non-severe category. If they are non-severe, you can certainly give something like a quinolones and something like ciprofloxacin IV. That will be good. And but if the patient is ill, and then you think that patient you should give broad spectrum, then certainly give broad spectrum antibiotic which will give a pseudomonas cover as well.
Okay, so thank you very much, sir.
Okay, right now that is the management plan, and then there are a few other points that we have to remember. That is what's called the feet infection, try to isolate organism, bronchodilators. In the long-term management of this patient with bronchiectasis, they are generally go on either oral or inhaled antibiotics. There's one recommendation some time ago giving what's called 6 weeks of antibiotic. And this actually came from a study, and where they said that this patient requires 6 weeks of antibiotic, and that improve their what's called quality of life and reduce hospital admission. But then that idea didn't go very well with the microbiologists, and microbiologists never liked this particular study, and then they always resisted this use of antibiotics, long-term use of antibiotics. So we don't practice that, but I know certain countries they do that, and but we don't do that. But some people they give about 6 weeks of ciprofloxacin, 6 weeks of macrolides, and they give that. And but there's one study, but we don't do that very much. Remember that they need a pulmonary rehabilitation, and that is not only postural, not only physiotherapy. When you say pulmonary rehabilitation, they get breathing exercises, they get walking exercises, and then they get a nutrition looked after. They look after their nutrition, because remember that their respiratory muscles need to be looked after. If you want to look after the respiratory muscles, they should get certain amount of exercises and certain amount of nutrition. So pulmonary rehabilitation program includes physiotherapy and postural drainage, that is postural drainage. And then the second thing is that nutrition, that is important one. And then the third one is certain amount of exercises to improve pulmonary capacity. So those are so safe pulmonary rehabilitation, including postural drainage and this thing. Also, they need vaccination, and annually, depending on the country's recommendation, because all the countries have got this recommendation now for the vaccination for the people who are having chronic lung disease, and also for the people who are even without lung disease over the age of 65. Now they have got what is called the influenza vaccination, and then all that, So that vaccination also part of this thing. In bronchitis, you think of doing surgery particularly when it is confined to one area. So that's why the HRCT can be very, very, very handy. And if you find HRCT that is only just involving part of the lobe, and then it's not spread to the rest of this thing, and best thing it allows, cut that out, and then so patient will be okay. This is particularly seen in one particular condition. I don't know whether you have heard. Have you heard about what's called Brock syndrome? BROCK''S. Brock syndrome? No.
No, sir.
Yes or no? No.
No,
No, sir.
No. Unless you have done a ward round with me for 1 month, you don't know. Brock syndrome is something that because of the childhood tuberculosis, and the people get right middle lobe, and you get lymph nodes over there. Because of the lymph nodes, in tuberculosis, primary pulmonary tuberculosis, you get what's called the Ghon's focus and the complex. Yeah, Ghon's focus and the complex of Frank, is it? Somebody's listening? And then
yes.
That's right. So they generally that heals, and that doesn't require treatment. That heals and patient remains asymptomatic during that period. Patient doesn't know that. So, but only if it occurs very early in the childhood, and you can get little damage because of the lymph node enlargement. You can get little damage to middle lobe, right middle lobe bronchus. And as a result of that, what will happen is that, these people, when they grow up, the right middle lobe has got a little collection because the clearance of the sputum and the clearance of the secretion is impaired because of this little bronchial narrowing and in the right middle lobe. So what happens, they get a recurrent infection here in that lobe, and then they can end up with the right middle lobe bronchiectasis. So I haven't seen a case during the last, let's say, 3, 4, 5 years, but this is supposed to be a common condition those days when the TB was quite, people used to get TB at the very early age, and they end up with what's called right middle lobe bronchiectasis, and then there is known as what's called Brock syndrome. And treatment of choice is that surgery, because you cut that out and then people will be okay. So bronchiectasis management very much like acute attack. You will treat with antibiotics and the bronchodilators and then this and that supportive therapy. And the long term, you'll have either oral or inhaled antibiotics and then pulmonary rehabilitation in a big way. I have one of my senior registrar. She went to UK and never come back, and she's working one of the respiratory centers in London, what's called Brompton Hospital, one of the leading hospital in UK for chest diseases. They must be busy now. What's her name? I can't remember. And when she came to see me one day, and she said that they have got what is called the no crepitation policy. So patient with bronchiectasis, they rehabilitate to a point that they can no longer hear any crepitation in the lung. So that much of intensive physiotherapy that they give these people, pulmonary rehabilitation, so that you don't have any secretion, basic secretion in the lung of those people. So that type of thing they do. So long term these things, and then immunization according to country schedule, and then surgery. On the other hand, you get what's called interstitial lung disease, and where oral corticosteroid or oral glucocorticoids are the mainstay of treatment, like prednisolone. And then they need prednisolone for a long time, because these are the people who have got high inflammatory markers. The biopsy showing that they have got a more cellular reaction, and then fibrosis. Their inflammatory markers are elevated, and those people you start on steroid. And then while monitoring their lung function test, you tail that off, but then sometimes you're unable to do complete tail of glucocorticoids. You think of long-term side effects, and then you have got what's called glucocorticoid sparing drugs, like MFM, mycophenolate mofetil, azathioprine, the cyclophosphamide. They all can be used. There are 2 new drugs I just picked up from the internet, and then no one knows exactly how they work, and they're supposed to be doing some, reducing the progression of the lung fibrosis. So I haven't heard about them, so I don't know. The lung transplant is something that people think about, that single lung transplant, and particularly when the patients sort of progress and then try to get what is called the element of copulmonale, and then that's the time that they had to get a lung transplant in other countries. A domiciliary oxygen is also used. I had one of my friends who had lung fibrosis, and he was considered not suitable for lung transplant because of his age. And then what he had was a domiciliary oxygen, and he used to travel to Sri Lanka with this oxygen cylinder. And it is not a huge cylinder, but it's a small cylinder, compact, and then he used to fly with that. And he of course died later on. So those people, they can get domiciliary oxygen as well. Okay. Right. Any questions?
Is there any place for physiotherapy postural drainage in acute management of bronchiectasis?
You always get a physiotherapist involved, but then you will find that it's very, very difficult to postural drainage at that time. What they do is a breathing exercises. So we get them to breathe, take deep breaths, so that the whole lung get, let's say, aerated. And then as a result, they now cough out. So you encourage them to cough out secretion as much as possible, but they generally don't try to do what's called postural drainage during the acute phase. It's difficult, really. So it's a different type of physiotherapy that you do during the acute phase. Deep breathing, mucolytics, good hydration, and then try to bring out sputum. So you can sometimes you can see the plugs of this one, what's called the mucus plugs, blocking, and then those can be sort of dislodged. Sorry, they can be dislodged by doing vigorous breathing and all. So that's what the physiotherapists generally do. And but they don't tap on their chest and all during the acute phase because that generally they can't tolerate it. So all this vigorous kind of pulmonary rehabilitation program takes place when the stable patient who are attending the clinic.
Sir, is there any place for tranexamic acid in hemoptysis in bronchiectasis?
Of course, yes. It's given for any bleeding from any site, like menstrual bleeding, GIT, after aerobic traffic accident. So if they bleed from any sort of place, and then tranexamic acid can be used. We have patients in the ward who are given tranexamic acid when they come with hemoptysis. Yes. From where do they bleed? So when the patient with hemoptysis comes, which vasculature from they bleed from which vasculature? What is the circulation? What vessels? Pulmonary arteries?
Bronchial vessels.
Bronchial vessels.
Bronchial vessels.
That's right. These are bronchial vessels, and people think that they bleed from pulmonary arteries. And I had one of the registrar when the patient had a very tiny hemoptysis. I said, well, you don't have to give that. But he thought that patient can bleed, have a profuse bleeding because with pulmonary this thing. I said, no, they don't bleed. Hello? Hello, can you hear me?
Now we can hear.
Yeah, sorry.
Yes, sir, we can hear.
Sorry, there's a power failure, and anyway, come to the end of the lecture. Is there any this thing? There's only one more that I just want to show you. That is, can you see the X-ray here? Can you see that X-ray?
No, sir.
No, sir.
No. I have not. I don't done sharing. Okay. Let me do it. Okay. Share screen. You should be able to see that now.
Yes, sir.
Okay. Right. Okay. Okay. Right. Okay. That is bronchiectasis. So if you get that kind of thing, it certainly doesn't need HRCT. So you can see that there's a fibrosis of the right hemithorax, and you can see how the trachea and the lower airway is completely shifted to the right side. Okay, can you see that? That trachea,
Yes,
which is
sir.
the intrusive part, and is gone. The ribs are crowded. There's a crowding of ribs, and then you can see even the herniation of the heart. That's very nicely seen here. Heart is herniated because the heart, you generally draw a line in the middle. You find 1/3 of the heart is on this side and the 2/3 on the other side. So 1/3 if you draw a midline, and the 1/3 on the right side and 2/3 on the left side. So you can see that if you draw a line here, and then is almost half of that here. So this is a lung fibrosis, probably because of old pneumonia, maybe tuberculosis, or some kind of lung injury, and then cystic changes all over. And you get on the other side, what is you get a compensatory emphysema. So you get compensatory emphysema on the other side. Ribs are here, ribs are crowded, here ribs are expanded and more parallel. So this kind of patient will have a lot of respiratory difficulty, and it doesn't really require HRCT. I would not bother really. This again, patient with a cystic bronchiectasis. Here you can see the fluid level. Can you see the fluid level here?
Yes, sir.
Yeah. So it's bilateral. This one is bilateral cystic. So diagnosis can be confirmed with this. You don't have to do anything else really. And if you want to see the extent of that, you can do HRCT. So this kind of patient, and depending on the age and all, you can stop at the level of just a radiograph. You don't have to do HRCT all the time. So don't start transferring all of your patients, to Karapiti for HRCT. And some of these patients can be managed without that. So I'm a bit selective when I do HRCT, because if somebody asks me to do HRCT on me, I would say no, thank you very much, because the amount of radiation that you can get with HRCT, huge radiation, a huge amount of radiation you get into the lung. So I would say no. And this is what's called tram lining. So this is what you can see that this is a quite non-specific kind of. You can see a little bit of cystic changes here and there, and this is increased bronchoscopal marking, so indicating that there's a bronchial hyperreactivity, and then cystic changes in the periphery. And this is what's called one of the classical features in bronchiectasis, what's called tram lining. This is the thickened mucosa. You can see the bronchial. This is a bronchial passage, and the mucosa is thickened. As a result of, you can see that, and here also it's thickened. So thickened bronchial walls can be seen in chest X-ray, and when they are parallel, you call them what's called tram lines. They're called tram lines. And sometimes you can get a small patch of consolidation here, and they are irregular, and you call them toothpaste appearance. So you can get a little bit of toothpaste here and there. This is not really a toothpaste appearance, and they are like a little bit of toothpaste. So this is a tram lining, and other one is a toothpaste appearance. Those are the features of bronchiectasis. And this appearance you can get in bronchopulmonary aspergillosis or something like that. Bronchoalveolar aspergillosis, that you can get in that condition as well. And so it's not bronchiectasis all the time. You can get in that aspergillosis as well. That's all. Okay.
Thank you.
Right.
Thank you, sir.
Okay. Yeah. I don't think I have any other lecture for you all this week. I don't think I have any other lecture. Right. Okay.
Sir, I have a question. So is there a place for corticosteroids in bronchiectasis management?
Inhale, this thing is yes, but then you have to be a little cautious. Because if you read the leaflet of this inhale corticosteroids, and they always say that, that when you use that in patient with tuberculosis and patient with suppurative lung disease. Now, bronchiectasis is actually, it's not a airway disease, because it belongs to suppurative lung disease. So it recommends caution when you are using. So I have got my patients on that. So I generally tend to give bronchodilators which are not corticosteroids, really. But certainly there are instances where you have to give that because you find that these people have got what's called bronchial hyperreactivity and they are coming with recurrent wheezing. So you have to give that. So when you give that, you have to be a little cautious. You have to make sure that the patient doesn't have ongoing lung infection and patient does not have tuberculosis. So I was reading this leaflet one day, and the leaflet has got a clear warning saying that you must always exclude the possibility of tuberculosis before you do that, and also that patient when you are using a supported lung disease, you might have little problems. So you can give that. Yeah, there are some patients who get that.
All right, thank you, sir.
Okay, so either you can do bronchodilators, long-acting bronchodilators like salmeterol or formoterol, and also you can say something like this one, what is called atropine-like substances, ipratropium bromide, and then there's a longer version now. So they are little more safer than inhaled corticosteroids. So I generally, what I'll do is I give long-acting bronchodilators, and then I give atropine-like substances, and then only if I can't control, only I'll give the other stuff, right?
Okay, sir.
Okay. Right. Okay. So see you sometime.
Thank you,
Thank you,
sir.
sir.
Bye.
Thank you.